Just give me half a minute. It is going live, and then thereafter we can start.
Okay, sir.
We can start now.
Yeah. So, good evening, everyone. I welcome all of you on behalf of Allergy Applied Immunology chapter. Today's second webinar on biological in allergy practice. I think the need of the hour is a targeted treatment for allergy disease future treatment. So, today's moderator is Dr. Tina, and I'll request our past chairperson, Dr. Krishnamurthy Sugio, remarks.
Good evening, and thank you, Dr. Narayan Reddy, sir. So, at the outset, let me thank and congratulate the team 2025 led by Dr. Neeraj Gupta, Narayan Reddy, sir, and Danesh Volokar for such wonderful activities and the EB team of 2025. So, we are having a very important discussion tonight on the importance of biologics. So, we are having a list of very esteemed faculties who are national expertise in this field. So, thank you so much, Neeraj Gupta and team for organizing this wonderful CME. Best wishes for the program. Thank you.
Okay, I'll request Dr. Tina to introduce the speaker and start the session.
Good evening, everyone, and thank you, Dr. Narayan Reddy, sir, and Dr. Krishnan Mohan, sir. And so, not wasting much time, we'll start with the series of our biologics in allergic diseases. So, yesterday we had a good insight into the pathophysiology of an allergen by Dr. Shalini, and she elaborated beautifully by her flow diagrams. We had also discussed about various biologicals available, their roles, action, cost, and various practical challenges. So now moving ahead in this series, today we have renowned speakers, and we all know that starting long duration therapy is really a problem in any child. Their parents have lots of questions, how it is going to act and how long, and what will be the growth of my child, how will be the immune response. So there are a number of questions. And so we have our renowned speaker, Dr. Satish Roy, here with us today, who is a US board certified allergist and in mind body medicine consultant and health lifestyle coach. He's an excellent teacher and a true academician. So we welcome you, Dr. Satish Roy, sir, and please take over and enlighten us on these various aspects.
Thank you very much, Dr. Goel. A very warm welcome to all our attendees. Just give me a moment. I shall share my screen. Are you all able to see my slide?
Yes, sir. It seems, sir.
Okay. Good. All right. Perfect. Just give me a moment. I'm trying to just optimize this. Okay. All right. So my talk for today, again, thanks to the IAP Allergy Immunology chapter, Dr. Neeraj and team. Gives me great pleasure to be speaking on this topic. Clearly, it is something that is very relevant, very important, and has a lot of implications, as I may say, in the right use of this entire I would call basket of medications. So at the very onset or outset, what I would like to do is just give an example of what the perception of asthma control is in Indian patients. Why this is important? Because when we talk about biologics, we are truly talking about using this in patients who really need it. And I think if it is used on a need-based manner, then the likelihood of having adverse events or unexplained stuff happening is much lower because the need will far outweigh any potential side effects. And so in this Asia Pacific Asthma Insight Management Study, there were 400 patients from across India who were evaluated, and it was found that 91% of Indian asthmatics believed that their disease control was optimal, whereas none of them met control criteria when evaluated by objective measures. They felt that 2 visits, unscheduled casualty visits a year, was completely normal. They also felt that short courses of steroids, even up to 10 times a year, were not unusual. And only 36% of these patients really had controller inhalers. Though this was largely an adult study, Adults are who take care of the kids. And if this is the perception of adults, you can imagine what the perception with children would be of these same adults. Why do I say this? Because it's very, very important to address the basics before we even consider biologics. So the basic workup and management of allergic and asthmatic diseases really needs a significant improvement all across our country. Inappropriate testing, especially even inappropriate allergy testing, followed by inappropriate prescription and unnecessary medications, including biologics, put a significant financial burden on the patients and families. Knowing that the WHO essential asthma list, for it to become universally available with the use of public health interventions, physician education, addressing modifiable risk factors, I get a lot of cases where people come to me asking that we have been recommended a biologic drug, do we really need it? And when a very careful allergy evaluation is done for these patients, one realizes that right from the allergen avoidance measures that are so critical for reducing a disease and its morbidity, to potential treatment of the allergies and then eventually the asthma, which is in many cases in children and allergic asthma. As we know, asthma in children, up to 80-85% of them are allergen sensitized and triggered. So I think that there is a huge scope for really narrowing down the real need for biologics, which I'm sure as per indications at drugs, you all will hear more about. So since the focus is on children with allergies, I've tried to restrict my talk to the three biologic drugs, omalizumab, mepolizumab, and dupilumab, which are approved between 6 and 11 years of age. Interestingly, if you go to the CDSCO website and see the approval of omalizumab, you will see that omalizumab truly is approved only for adults with severe asthma. Some of the other indications we take from the international scenario are largely indications that are extensions of this approval that we have. The most common side effects that we commonly see with biologics include pyrexia, and this is true for all biologics: fever or feverishness, headache, soreness at the site of injection, abdominal pain, sore throat, sinus pain. And additionally, some people may feel fatigue or weakness, which is called asthenia, drowsiness, nausea, and fatigue. Now, recognizing that this can occur with any drug, we shall go into specifics with each of these drugs. Omalizumab, when we look at the side effects of these in children, feeling dizzy or tired, having pains in the arms or legs, having some itching or skin rash, having pain or discomfort in the ears, abdominal pain, nausea, fatigue, these are very common, and technically many of these side effects will resolve with long-term usage. And in the long-term usage, we will find that there are also ways to manage this in a better way with regards to dosage, timing, pre-medication, sometimes with certain antihistamines, sometimes even with NSAIDs where necessary, can be beneficial in these children. We recognize that omalizumab is the biologic with the longest extensive safety data. It's been around since 2003. I was actually involved in some of the pediatric trials with Dr. Henry Milgram, whose name you see down in the references when we were at National Jewish and we were doing the trials in the 4 to 11 age group. And hence we were some of the earliest to use this drug in severe asthma, which was the primary indication at that time. And in these cases, besides the minor reactions, delayed allergic type 3 reactions, which can occur anywhere between 1 to 5 days and can involve, again, low-grade fever, arthritis or arthralgia, and other manifestations of a type 3 reaction are largely due to immune complex formation. And this is something that needs to be monitored even in the long term. This is one of those side effects that, if it is present, may lead to discontinuation of the drug if it cannot be managed with appropriate medications such as antihistamines and corticosteroids. If it is recurrent, then it leads to discontinuation. Systemic hypereosinophilia or Churg-Strauss syndrome. This is also associated with marked eosinophilia, can have vasculitic rash, worsening pulmonary symptoms, cardiac complications, neuropathy. And again, when we look at the safety data that's there, these are things that are largely seen in adults. The pediatric data does not reflect these type of reactions as much. And hence, that is a good thing for us when we are using it in kids between 6 to 11 or 12 years of age and up, and even adolescents who largely follow the adult data. I think the main adverse event that is very, very important to recognize is having what would be an anaphylactic reaction, which we know has an incidence of about 0.09% in children also. And I have certainly had a case in America, haven't seen any in India, where due to anaphylaxis, this was an adolescent girl. We had to actually discontinue omalizumab, and hence the recommendation to observe the first 3 doses, and the risk being there for up to 24 hours after the injection is a very, very important one. And if these symptoms are there, then the use of adrenaline becomes very important in these cases. Some participants can also experience platelet count reduction, but this is not persistent and it's not associated with bleeding episodes. There's also no decrease in hemoglobin, and so this becomes something that requires careful monitoring. And in that situation, the use of the drug can be continued. IgE, as we know, is very, very important for protecting against helminthic infections. And hence medications that lower IgE level, and this would be across all Th2 drugs, are very, very important in helminth endemic areas, especially a country like India. Though we may say that in the larger metro cities, this has gone down, I think across the country and even in some of the low-income areas of metro cities, these are still very much active issues. Though these almost never lead to any systemic or serious complications, it is something that we have to have a high radar for. And definitely with omalizumab or even with mepolizumab or dupilumab, these are relevant and important. And this is one of those side effects that we have to be careful about. When we look at a 52-week trial for omalizumab that was done for about 225 patients between the ages of 6 and 12, upper respiratory tract infections and headaches were the most frequently reported adverse events. And this was again from some of the earliest trials that were done for omalizumab. You can see this was done by Bill Berger, published in the Annals of Allergy, Asthma, Immunology, 2003. And we will come to this URTI and what it really means. Patients had also developed urticaria, which resolved with antihistamines, and only in one patient did it have to be discontinued. So the same urticaria, which now chronic spontaneous urticaria, omalizumab is approved for use, some patients can actually develop urticaria as a result of omalizumab. Anaphylactic reactions had not been seen in this study with children. Neither were any adverse events of serum sickness or immune complex formation. But certainly as we get into the slightly older kids or even adolescents, we have to be very careful in the long run about this, because this can show up at any point of time. This doesn't necessarily start in the very beginning that these drugs are used. Interestingly, no anti-omalizumab antibodies were detected in any of these children during this 1-year trial. And hence we know that the efficacy of these drugs can be really long-term. And the goal always is to use any form of desensitization or immunotherapy so that we can then reduce the need for omalizumab in the long run, because again, we do not want these drugs to be used indefinitely for prolonged periods of time. There were no new serious adverse events compared to the 28-week trial that was done prior to this. This was the extension to the 52-week trial. When we move on to mepolizumab, and here I will later on discuss the upper respiratory tract infections with one of these agents also. When we look at the MUPITS-2 trial, which was carried out specifically in children, clearly there was a reduction in asthma attacks for children, but the reduction was only 27% compared to 50% for adults. And the IL-5 levels in children tend to be lower than they are in adults, and hence the efficacy of mepolizumab in the very young children, though it's approved down to 6 years of age, is something that we have to really consider on how valuable and important it is, and whether some of the other available agents may be better, because IL-5, which is the target of mepolizumab, in this study showed that there was improvement, but not as much of a favorable outcome as was seen in adults. Also in this study, there were no clear evidence for any increase in infection or neoplasm. Subsequent studies have also shown that. They have also shown that there is no necessary increase in helminthing infections, but the risk still remains because eventually these will influence the levels of the agents that are very important in bringing the eosinophils and the IgE to the sites where the helminths have to be fought. When we look at dupilumab, Dupixent, again, since this has an effect on both IL-4 and IL-13 by blocking the IL-4 alpha receptor, which is shared between IL-4 and IL-13, there was clearly increase, because of this, the classic changes that we see of nitric oxide production. Even in children, when we are considering dupilumab, when it is available in India, it is approved by the DCGI, but not available at this point of time. Because of what we are told is short supply across the globe. This is something that will become a very important marker in knowing which kids could benefit from it. We know that when dupilumab is used, there is a rise in blood eosinophil count. Long-term monitoring shows that this hypereosinophilia is transient and self-limiting. It does not necessitate treatment discontinuation, and the rate of parasitic infection was around 2% in children on dupilumab, and this was not considered to be serious or severe. And an even smaller number were associated with eosinophilia. So clearly, this drug has been used in pediatrics. There are now almost 8 indications for it worldwide. Not all of them necessarily are in pediatrics. And this is a drug that we clearly have to be on the lookout for in the near future, because there is a lot of advantage and benefit with it. Dupilumab has also been associated with increased incidence of upper respiratory tract infections, 12% versus 9% in the placebo. In the excursion study, there was nasopharyngitis, pharyngitis, and upper respiratory tract infections that were more common, and in this treatment group compared to the placebo, and eosinophilic antiviral effects. And this, I think, is a very important point, because when parents ask us about what kind of side effects we can expect or see, the increased risk of upper respiratory tract infections, as you saw in the very first slide that I show of common side effects, sore throats, rhinitis or rhinosinusitis or infections of the upper respiratory tract. Eosinophils are not important only for antiparasitic effects. They're also important for antiviral effects. And it's possible that the blockage of the eosinophils in the tissues may be one of the reasons why nasopharyngitis, pharyngitis, or upper respiratory tracts infections may be more common, given that kids go to school or daycare. They also are exposed to a lot more viruses. This is something that we would need to monitor. And if the child is having too many infections, which we feel may have started only after the drug was initiated, we have to consider this also while looking at this. Also, some ocular side effects have been noted, such as dry eyes and conjunctivitis, and this should be discussed with patients. Also, dupilumab has shown to be well tolerated and very good safety profile in the pediatric population for the several indications that it has. Benralizumab in pediatrics, we know that under the age of 18, it's not approved. If anyone is interested in knowing the pharmacokinetic and long-term safety data, certainly there is information out there. I've just put this paper out here. But since we are discussing largely children, not adolescents or adults, I'm going to focus on this as of now. So when we think of biologics in pediatrics, with 5 US FDA drugs approved for biologics in pediatric age groups, there are still very big knowledge gaps. Even when you look at omalizumab, the longest study that is there in terms of data is 4.5 years of omalizumab use. It is not that long, especially in the pediatric age group I'm talking about. And hence the long-term efficacy and safety of biologics in children is something that still needs to be studied. I know that growth was asked of separately. Growth has been looked at only in the Sentinel trials or the 1-year trials. And there was no difference in the growth of children on biologics versus those in the placebo arm or in the group that were being followed with standard of care. The way I would look at it is, if you're having to use high doses of inhaled corticosteroids or having to give frequent oral corticosteroid bursts, which is one of the reasons why you would be considering biologics in children, clearly the biologic, by reducing the steroid dependency or the steroid need, becoming steroid sparing in some ways, will actually enhance the growth of the child rather than worsen the growth of the child. Comparative efficacy between biologics is lacking in the pediatric age group. Asthma endotypes and phenotypes recognizing the under 5 Wheezers versus the actual asthmatic kids, the allergic versus the non-allergic or the infective type. There is still a lot that needs to be done. The obese asthmatic who possibly would benefit more from something like tezepelumab when it gets approved for these age groups or is available in India. Also recognizing that biologics started early can modify the natural history of asthma, and hence long-term studies utilizing allergen immunotherapy with biologic use in childhood, whether it is also with food desensitization and biologics being used, I think are very, very important studies which are getting underway and being done now and will give us very good data in the near future. When we look at the future directions when it comes to children and biologics, further trials need to be carried out in appropriate populations to establish the optimal biomarker cutoffs for children. We are currently using cutoffs that have been designed through the adult trials. Whether it comes to the IgE for omalizumab, the peripheral blood eosinophil count for mepolizumab, or the FeNO for dupilumab, we recognize that these cutoffs are adult cutoffs that we are using in children. In children, we recognize that their IgE levels may be higher than adults. We also recognize that eosinophil counts may be higher than in adults. And hence, having proper cutoffs for pediatrics is something that is extremely important for these biologic drugs to have. The need for head-to-head studies comparing different biologics, especially for severe uncontrolled asthma, is also something that's very important. And then identifying suitable endpoints for treatment and how to maintain control following successful treatment when and if ever the treatment can be weaned. I would say that in children, especially in pediatric age group, it should not be an if ever, it should be definitely weaned. And if we do the other things right, which is take care of their comorbidities, take care of their allergies, take care of their diet and lifestyle, take care of their environmental exposures, it should be possible to take kids off biologic drugs. And that's how I use and practice in my clinical practice. With that, I shall end my presentation. I think I've completed my 20 minutes. If there are any questions that may be there, we can take them now.
Thank you,
So
Dr.
thank you very much again for inviting me to this session.
Thank you for such a lucid and insightful talk. Definitely, we have some minor side effects are always there with any of the drugs we use. And so I think if a proper counseling is done to the parents before starting the drug, the acceptability is better. And as you have told, rare side effects are there, they are rare, and we should be monitoring them. And if there is a recurrence, then we lead to discontinuation of drug. That is the short gist of your thing. And correctly pointed out that corticosteroids are more harmful in both growth and catching up infections and immune response compared to biologics. So here Dr. Neeraj has one question, sir. So what about the use of biosimilars in comparison to biologics, because they are little cost effective and economical?
So I think that in my experience, since I started practicing in India about 14 years ago, I have had a reasonably good experience with the biosimilars, especially for omalizumab is what we're talking about. And I can say that comparative efficacy has been very similar to what was with the original product, which was Xolair. Having said that, there are concerns raised by people about the quality or about the efficacy, but in my practice, and like I said, I'm very, very cautious about using biologics in children. My experience is largely with adults, chronic spontaneous urticaria, severe asthma, asthma with nasopharyngeal, with polyposis. And I have found the biosimilars to do quite well. And I have several cases of chronic spontaneous urticaria in teenage or upper teenage or young adult and adult age groups who have done very well with the biosimilars. So I don't have any concerns with the biosimilars, if that's the question. I think they can be used, and cost saving is always a blessing for the patients. If one finds that with a biosimilar, they're not getting the desired result, if the question is asked to me, should we then use the Sentinel product, the original product? I would say rather relook at the case and consider a different biologic rather than trying to use the same biologic from the original manufacturer. Again, having said that, every case is unique, every case is different, and we would need to look at it on a case-by-case basis.
And another thing you wanted to ask, though you have already told that you have to keep a high cutoff values for IgE and eosinophil counts in India, especially in a rural area. But is there any specific data you have encountered, comparison of these two in rural areas and the other cohort?
I don't think I have come across, and if there is any data, I would love to, for anyone to share it with me also, but I have not yet come across. What we do know that, through the studies that Dr. Mahesh and his group have done as part of Europreval, IgE levels in kids in India are definitely higher than the average that we see across the world. And probably even to the level of where we take 100 or 150 as a cutoff, 250, 300 was not unusual for children. And hence, the choice of using a biologic just because the IgE level is high is a concern for me. And I certainly don't use that as my only criteria. I look at a very holistic picture, look at multiple biomarkers, look at the trajectory, the history, and everything, and don't rely on a single agent. It also puts a challenge with regards to dosage, because when you think of dosage, that's purely based on the level of the IgE and the body weight of the child in some cases. And so again, there, I think having higher than normal IgE levels in our country puts a little bit of a burden in terms of the dosage we have to use. But no, I'm not aware of any specific data that has looked at it in relation to the use of biologics.
So probably we need more studies in the.
Absolutely. Absolutely.
So I think we don't have any further questions, sir. An excellent session. Thank you so
Thank you.
much for sparing your time.
Thank you. Thank you. My pleasure. Thank you for.
Thank you. Next, moving ahead, any other questions by our audience? So let's move ahead. And so now the next is I invite Dr. Vijay Varat, who is a senior pediatric pulmonologist and allergy specialist from Sai Allergy Asthma Eye Hospital, Pune, with an extensive experience of using biologics in different conditions. So, sir, whom to start with biologics? What are the positive, negative markers? We would like to learn from you. So over to you, sir. Please share your experience.
Thanks, Tina, for introduction and giving me the opportunity by Dr. Neeraj and the IAP Allergy chapter. And as I've been given the topic on biomarkers specifically, and how to interpret that and how it can be helpful to our severe allergy patients. As Dr. Sitesh has already made my job easy, like giving the whole perspective in biologics in children. And since yesterday also, like the previous speakers have talked more on biologics a lot. So if you see the allergens, we all know, like yesterday also Dr. Shalini talked about that, how from the dendritic cells from the skin to the traveling of these interleukins, TSLP, then basophils, mast cells to Th2 cells, then immunoglobulins, and then the IL-25, IL-33, and leading to the asthma, rhinitis, food allergies. So accordingly, as already Dr. Sitesh shared, like where we are using the biomarkers or biologics is where those patients, they are repeatedly getting steroids, oral or parenteral. Even 2020, when the IAP allergy chapter, I spoke on use, abuse, and overuse of anti-allergics and steroids in India. So I collected whatever the data, and I found really shocking, like even the children are also used a lot of steroids in India. And so these cases where the repeated steroids are used, the severe asthma or severe allergy patients, we have to have a different phenotypes and endotypes. And accordingly, we have to manage these patients. So even there are studies done where they have shown that most frequent endotype of asthma representing 60% of the cases is atopic, and then non-atopic, where 25 to 30%, approximately 5 to 10% of the patients suffering from asthma have severe refractory asthma. And based on the existing data, 55% are eosinophilic, 20% neutrophilic, and 18% oscillogranulocytic, and 6% mixed form. So the multidimensional approach is required in these patients where the phenotyping and the comorbidities are very important. So we have to understand it's a progressive serious disease where each and every treatment does not fit like for all. And the biomarkers can be a very important in these severe allergy asthma patients. So it's still we are learning that in India because of the constraints. Recently only we have all these oscillometries and all the pediatric data also the CRF had tried in Pune. And I think Dr. Neeraj has also done a lot of work in AIMS. So we'll be having that, so it will help in our patients too again. So what is a biomarker? Basically, it is a substance, structure, or process that can be measured in the body and can influence or create the incidence of an outcome of the disease. So they can be diagnostic or predictive in nature. Early onset allergic asthma is characterized by the presence of specific IgE for the allergen, and we detect it with the skin prick test or specific IgE immunocap or CRD. And then late onset hypereosinophilic asthma can be characterized by elevated peripheral blood or sputum eosinophils. Practically, sputum eosinophils we don't do it. It is done in mostly research setting. And what is the ideal biomarker which is reliable, minimally invasive, easy to collect and measure, inexpensive, can be used to identify a phenotype or endotype, treatment response, measure changes in disease activity, and confirm the diagnosis. So most common is the T2 inflammation, and where the pathways which are affected in these severe asthma patients and measured by the eosinophilia or pheno practically. And the allergen sensitivity and the symptoms we have to clinically correlate also, because there are other factors also where eosinophilia can be high, as Dr. Sitesh said, in Indian scenario. And pheno also, there other factors can affect it. We'll see later on. Eosinophils also, they are affecting the airways with the mucus plugging and thickening. And they are seen as a congruent with the symptoms, severity, worsening of lung function, and even near fatal events. So while choosing the biologics, the eosinophil levels, specifically in omalizumab case, where we want to use it, the patients with the 150 or 500 cells per cubic microliter, where it can be used, while the patients where 300 to 500 cells per microliter, where the IL-5 or the other blockers can be used. In asthma, if you see, then mepolizumab, benralizumab, which are available in Indian scenario, dupilumab, it was in pipeline, but still it is pending. And as rightly said, it is a shortage because I am doing a clinical trial with dupilumab, and they were initially planning to introduce, but now they have stopped the recruitment also because the shortage of it is there worldwide. Some of the patients, specifically adolescents and adults, the neutrophilic asthma can be there, and where these biomarkers are very important. IL-17, where it has to do with the type 17, TS17 immune response, which induces the chemokine IL-8 in the structural cells. And several triggers have been shown to induce IL-17 and recruitment of the neutrophils to the airway, including the infection, air pollution, cigarette smoke, irritants, intensive exercise, and cold air. So if you see Indian scenario, already infections, air pollution, BD cigarettes, tobacco burning, chulas, they are very common. So we'll come to the cases like a Kashinath, 12 years old male child with severe asthma, significant dry skin, ocular allergy was there. Since the age of 7 years, he was diagnosed with an asthma with repeated oral steroids. In spite of all the treatments, nebulizations, he was diagnosed by pediatrician also. Then he had been to pediatric pulmonologist at the corporate teaching hospital. Monitoring with oscillometry, spirometry was continued. Omalizumab was given for 6 months. Not much response. Weight has already increased, obesity. Last 1 year, severe exacerbations requiring 3 admissions with parenteral steroids. The father had a snoring, mother eczema, sister has rhinopharyngitis. The patient was referred to us. The signs of allergy were already there. Chest X-ray showed the prominent bronchopulmonary markings. We did a pheno, it was showing 17 ppb. Total IgE was 450. Absolute eosinophil count was 1250. Allergy testing showed the pollens and dust mites. Then after consultation with the parents and looking at the so many steroids, his obesity, his lifestyle was affected, he could not play, he could not go out. So many restrictions were there. So we consulted and then we started on a benralizumab, 30 milligrams subcutaneously, 4 weekly for 3 doses, and then we gave a 8 weekly dose. And till that time, the other things also like precautions and inhaler was continued. Child showed a very good response after 3 months. Last 2 years, mostly asymptomatic with mild exacerbations, control on Symbicort 80 milligram, and precautions and desensitization on dust mites and pollens is continued. So as already it has been discussed, like yesterday also, Talwar sir said, like some patients where they don't show the response to one biologic, we can shift to the another one after the proper analysis and clinical correlation. XL nitric oxide is produced by NO synthesis, some of which can be induced by the cytokines. And these elevated NO levels can be detected in diseases with prominent IL-4, IL-13 expression in a type 2 asthma. So it is a very valuable marker in pediatric asthma also. Even 3 years old children can do very well. And if you see according to the severity and control also, we can analyze. So as a predictive value, more than 20 ppb in type 2 asthma. Monitoring if FeNO levels more than 30 ppb are significantly associated with uncontrolled asthma. For children between age 3 to 7 years, the cutoff value of more than 15 ppb predicts the uncontrolled asthma with a high specificity and accuracy also is much better. So accordingly, the different biologies can be given in the patients with even recently I had a patient from USA, and this patient specifically the IL-4, IL-5, IL-10 and IL-13 were analyzed. You can see the values over here. And he had a comorbid urticaria also. So the basal activation test also done. So in Pune, 20 patients of severe asthma, we did a biomarker analysis with the university PhD student. And we found this how the IL-4, IL-7 proliferation into this Th2 inflammation patients was correlating clinically also to these allergic patients. So even IL-13, IL-17 levels were analyzed in these patients. Again, another case, 9 years old from near Sholapur, referred by a pediatrician for asthma. He had been to most of the therapies, 3 times admission. Last year received 4 times parenteral steroid, oral steroids on Foracort 400 milligram twice. After the spirometry, we added on a 3-drug combination and premium, and he started showing some response. He was better, at least no admissions, but significant severe episodes in the night, even twice required again oral parenteral steroids. We did a skin test, the mites pollen sensitivity. Now he was controlled because he was already given up steroids for a few days. So total IG we did 450, FeNO was 30 ppb. And we started on according to the weight and his IG level, omalizumab 300 milligram. Within 3 months, much better. After the 4 dose, now only on Foracort 100 milligram once at evening. No nebulations of oral steroid. Desensitization continued, and we continued with the omalizumab. So again, since yesterday we have discussed about the IG, how it has a role in asthma and allergic conditions, like the cross-linkage of IG with the allergen and binding to the mast cell and releasing the inflammatory mediators and symptoms. So total IG, this is the chart where according to the levels, we can use the omalizumab. What type of dose, like from 75 to 300, 600 milligram. In India, we don't have 75 milligram or 300, 600. So we have to adjust with the 150 milligram. While giving always, it should be given under separate sites, not in a one syringe only. And generally, while giving these patients, we always change the sites because it should not cause a subcutaneous atrophy and all later on. It has repeatedly sites on the same sites. Again, there are studies done where omalizumab has shown a very good effects on the reticular basement membrane thickness with the biopsies also from the patient with severe persistent allergic asthma. And reduction in thickness may help to reduce the airway remodeling. Eosinophilic infiltration also, it decreases the infiltration and reducing the numbers will reduce the symptoms. And by reducing the reticular membrane thickness and eosinophilic infiltration, it improves the lung function, reduces the symptoms, enhance the quality of life for patients with severe persistent asthma. So even we did a trial recently. It was adults above 18 years, IL-33 blocker, where also even more than 150 eosinophil count and FeNO levels more than 25 patients with asthma and COPD. We had a very good 28 patients we enrolled. So the future will be on these patients specifically, where as a steroid sparing treatment to avoid the side effects of that. So those patients who have a very good remission with the high blood eosinophil count, high sputum Ig levels, and better lung functions and lower BMI. So obesity associated asthma is also very important phenotype where wheezing and the symptoms are more. So it is negatively, the weight is negatively correlated with the lung function. So again, in pediatric asthma with obesity, the another biomarkers are in studies, the leptin, adiponectin. We can do C-reactive protein in Indian setups like cytokines also. I think within few years we'll be doing in India also, because during the COVID, at least IL-6 levels we're analyzing the same way. I think it will be really helpful for our patients. Then fatty acid metabolism markers also can be analyzed. So these patients specifically, because as in adolescents, the obesity has increased a lot. So anti-IL-7 and anti-IL-23 therapies will be helpful. At present in Inamdar Hospital, we are doing a trial with GB0895, the drug. We don't know the name of the drug because it is under trial. And 6 monthly interval we are using. So if such type of therapies will be for such severe asthma patients, definitely the patient's adherence will be much better and the benefits will be there to avoid the steroids. Again, impulse oscillometry can be a very valuable biomarker to decide about the biologic therapy, not only biologic, even to adjust the dose of inhalers also, controllers. So the parameters like R5, AX, and X5 can predict the asthma exacerbations and help identify patients who may benefit from the biologic therapy. So monitoring can be done in these patients, and it's very easy to do basically. It's not like a spirometry. So even adults also can't do the spirometry. So these oscillometry and FeNO will be really useful to the pediatric patients. Then serum periostin is now available in India, I think last 2-3 years. It is an extracellular matrix protein induced by the IL-4, IL-13 in the airway epithelial cells and lung fibroblasts. So more than 45 has another potential candidate in a T2 high asthma. So elevated levels correlate with the airway eosinophilia and decline in FE1 and predict the response to ICS. So these biomarkers, accordingly, these biologics are used. So even the dipeptyl peptidase 4 in serum or airways can be analyzed in the patients of eosinophilic or exacerbated respiratory disease, more in adults basically. So comparison of type 2 inflammatory biomarkers in asthma, as already we discussed. So even in allergy point of view, like I did around 7 to 8 clinical trials for these biologics, like 3 omalizumab trials. One was urticaria and asthma, where even more than 30 Ig level was taken as a significant with the clinical presentation with spirometry and other things. So even the same way, this tezekimab trial also, the Ig level is considered more than 30. So that is significant for this patient. Even absolute eosinophil count more than 150 is also significant in these patients. So accordingly, these biomarkers. So again, limitations for this will be according to they do not correlate clinically directly with the asthma severity. Elevation is not specific to asthma. Elevated in atopic dermatitis, allergic bronchopulmonary aspergillosis also. Blood eosinophils affected by weight, allergen exposure, steroids, and infection. Optimal cutoff value varies by the therapy. Elevation is not specific to asthma. So also in allergic rhinitic drug reactions. Then sputum eosinophils are in research setting, and FeNO affected by the age, weight, sex, smoking, and respiratory infection. So we have to always select the patients very carefully before starting the biologics. It's very important. So besides other these interleukins and all, the TSLP is the future now study, as Talwar sir said about that. So even ocular allergy is a very big problem now. We are treating so many cases, more than hundreds of children. We have given a omalizumab, which is shown a very good efficacy in a severe ocular allergy or VKCs. Like this child also, seal ulcer was there, intraocular steroid was addressed, but we did not give that. And after the analysis, we used the omalizumab and he had a very good recovery. So even the biomarkers into the cytokine and chemokine tier levels can be analyzed in ocular allergies. So I think we have another session for ocular allergies, so I will not go into details. Again, as Dr. Siddesh said, like urticaria is a very big problem now post-COVID, and there, after the other, like any causative factors, if the patient is symptomatic, and all of us know about guidelines by the dermatology as well as AACI, we can use the omalizumab. Even 150 milligram omalizumab is very useful in most other cases. They don't require a higher one. Very few cases require 300, 450 milligram. Some of the patients, even total Ig after omalizumab increases because of the complexes form over there, and prolonged half-life of Ig, being an IgG1 antibody with a half-life of 26 days, prolonged the half-life, contributing to increased total Ig level. So the patient will be confused. So always after using the biologics, I never say the patient to repeat it. I always say after 3 to 4 years. Otherwise, they will be again confused, and then it will be difficult for us to counsel them. So even 82.6% of the patient had elevated IgG levels after the 12 weeks of omalizumab treatment, with a significant increase in total Ig levels observed in chronic urticaria patients. Another biomarker which is very well studied and which has shown a very good efficacy. In India, we don't have that for the airway remodeling modulation. Basically, galectin-3 is a matrix protein that plays a crucial role in airway remodeling. Its presence can be detected in serum or urine, making it a potential biomarker for predicting treatment response. So the role in airway remodeling, they have shown that bronchial RVM thickness as well as eosinophilic inflammation, and for the muscular and fibrotic components, it has been shown as a very good biomarker to predict the modulation of the airway remodeling in these patients. So detection of galectin-3 will be helpful in our patients. This was a patient from Bandra, 17 years, adolescent with early childhood. She had eczema, treated symptomatically. In between, she was okay, but now adolescent eczema was very significant, affecting most of the part of the body. The father had eczema, psoriasis overlap, mother had also rhinitis with dust allergy. With repeated steroids, methotrexate was given because of the side effect, they stopped it. Serum Ig was 1600, eosinophil count 750. Skin test showed dust mites. After counseling for dupilumab, they were not ready because they had like above 18 years. So omalizumab opted 300 milligram monthly. Within 4 months, had a very good remission. Last 2 years continued on it with desensitized for dust mites. Again, we are increasing the gap now, 1 month, 21 days that way. So atopic dermatitis, mainly it is a Th2-driven disease characterized by the expression of IL-4, IL-5, IL-17 biomarkers. So these biomarkers, once they are done in India routinely, it will be really helpful in our practices. Again, patients showing a upregulation of the Th22 response. IL-22 is the most evaluated marker for disease severity, and its levels were also shown to be predictive for a biologic therapy. And in childhood atopic dermatitis, Th17 and 9 responses were found, as demonstrated by the higher levels of cytokines, like IL-17A, 19, and 9 respectively. So another child with 2 years, 6 months. This child had eczema because of some foods or colors in syrups and all. So they were taking some precautions. But 3 months back, while playing in a kitchen around, he had a sudden anaphylaxis rush to the hospital. After discharge was referred, we did a sensitivity test. Milk casein was significantly in a CRD. Total Ig was 270. Father has and mother has also allergy. Started injection omalizumab 75 milligram. After first dose only, even the improvement was seen in eczema also. Now the third dose of omalizumab we have given, because even the inhalation of BOS B8 from the air also can cause anaphylaxis. It's rare, but some of the patients can be also, such patients will be really selective for the. So even this CRD can be also one of the biomarker in such patients. Again, we have another session for that, so I will not go into the details on that. So this was a 17-year female with the vaccine-induced anaphylaxis. Some of the patients with significant urticaria angioedema and the drug allergies and food allergies, the basophil activation and mast cell activation test, because as we know, pediatric mastocytosis, there are chances of anaphylaxis. These biomarkers can be analyzed for these patients. So another Specifically, anaphylaxis patients, serum tryptase within 2 to 3 hours is much better. After 24 hours, we can look for the normal level of it. Histamine level, platelet activating factor, and specific IgE antibodies for the specific allergens. Other biomarkers are studied now, like a kinase, CCL2, carboxypeptidase A3, dipeptidyl peptidase, and basoglanine. So in India, it will take some time for that. So summarizing, the precision medicine is important. So while using the biomarkers in these patients who require a repeated oral or parenteral steroids, we have to identify these patients with the different phenotypes and endotypes. And more studies are required continuously, and the classification of the allergies should be done. And after the proper biomarkers, improvement in the understanding associated with the different types of allergies, asthma, opportunity to have a good quality of life to control the severe uncontrolled allergies. These biomarkers can be used as a fine-tuned treatments, reduce the corticosteroid use or doses, improve the quality of life, and to bring them to the normal sensitivity. So these are different type of biomarkers already discussed in yesterday, so I will not go into the details of that. So identify the phenotype, determine the endotype, choose a biologic, use a specific biomarker for that, and then consider which patient requires what type of biologic and use it. So they are really helpful in selective, important, where the side effects of the steroids are there. And then we have to monitor also the patients. As Dr. Sitesh rightly said, like there are studies where it has been shown that specifically omalizumab, third or fourth dose, they have a significant anaphylaxis. So not on the first dose also. So some of the patients we have to be very careful, always keep the patients. During COVID, my patients, we give omalizumab at home also, but always be careful about that because sometimes omalizumab has these side effects. Other biologics, like specifically now, our 10 patients of dupilumab trial are there. They are taking at home also. We did not find any side effects that way. Thank you. Thanks a lot.
Thank you, sir. Thank you for such an engaging presentation. And it was really a privilege to hearing you. And so we could get that before using biologics, we should use the proper biomarkers, and there are many new biomarkers coming up in the pipeline. So we have two questions here by Dr. Neeraj, and you would want to know that the minimal and maximum duration of available biologics in India in a given patient. How soon we can start if the biologics are needed?
Actually, looking at the cost of the therapy, most of the patients, they require for 1 year. And most of the patients have shown a very good results. Very few patients require, only 2 patients of mine, but they are adults only. They are requiring for 3 to 4 years and they don't want to live basically. They are very comfortable. That's why. But most of the children's, I think, whatever I have used it up to 1 year until with other managements, allergy management, precautions and breathing exercises, lifestyle modifications and all, they show a very good response. So maximum up to 1 year, children, they require it.
Hello, am I audible? No?
Yes, yes.
Yeah, sir. So other thing is that how soon can we start with the biologics? I mean, should we give weightage to immunotherapy and other treatment and then go for how soon should we start?
See, basically, biologics are targeted therapies and where we want to reduce the steroids, basically as a steroid sparing treatment. So suppose the patient we want to control the inflammation and he is requiring repeated steroids, then we should not wait for the immunotherapy because immunotherapy is going to take its own time. Rather than that, as yesterday also we discussed, even Dr. Talwar sir and all, it is a contributory to that for the immunotherapy. And there are studies also done where it has been shown that this type of severe asthma or severe allergy patients, if the biologics are given along with the immunotherapy, allergen avoidance and all, they help a lot for the immunotherapy also to have a good action for that, to not to have a relapse and a very good remission that way. So there is no need to wait also.
How about in children less than 6 years of age? Like biologics usually recommended age is 6 years. So should we wait for the child?
Food allergies I'm using, I have around 8 to 10 patients with a severe food allergies. Even one child is 1 year, 5 months old of the IS officer only. The child has a significant milk allergy. Some children are having a multiple food allergies there. Most of the other children above 6 years, asthmatics, as I said, few only 3 to 4 patients with a severe asthma, I'm using that. And some of the patients With the urticaria, maximum patients are on biologics. Children's, adults though definitely. But otherwise, asthma, they don't require much. I mean, they are controlled very well with the other things. Because anyway, in Indian scenario, very few people are guided about the allergy test and all. So that allergy test and avoidance measures with the proper control of the dose of the controller medication, even increasing, or even the now precision devices have come to have a good deposition. So they also get controlled.
Another question is by Dr. Neeraj that, like for a child, we start with an omalizumab of around 100 mg. Okay, so we don't want to waste the injection, which is a 150 mg. So can we give that in full dose, or should we increase the interval for the next injection?
Actually, I use it full dose, but practically. It's off the label. I have done that. I'm using also.
Not seen any
I have
side
got very
effects or
even
reaction against it.
Master Drish is there with a severe milk allergy, and he requires basically 100 milligram only. And I'm using 150 milligram because I don't want to waste any. I mean, it does not have any side effects,
Yes.
as such, so nothing to be.
So it was safe with you. So thank you so much, sir. And thank you for sparing your valuable evening with us. It was really a privilege listening to you. Thank you, sir.
Thank you.
So moving ahead, now I would like to invite Dr. Soumya Nagarajan, who is hello, Dr. Soumya. She's a
Good evening.
senior pediatric allergist and immunologist from Kangaroo Care Women and Children Hospital, Bangalore, and leading food allergist, and with her experience over decades. So please, Dr. Soumya, enlighten us about your experience and the guidelines, what they say about the role of biologics in food allergies. Over to you.
Thank you, Dr. Tina, for a very kind introduction. And I would like to thank our chairperson, Dr. Neeraj, and the entire chapter for giving me an opportunity to be a part of this August forum of biologics, which is probably in the omics era. I think biologics is what is the next big thing which is being mooted in the management of allergic diseases. So I think in the food allergy and eosinophilic esophagitis are biologics the next frontier is what is my assigned topic. And before we dwell into the biologics in the context of food allergies or the eosinophilic esophagitis, the first few slides I would be probably taking through a little bit on food allergy and eosinophilic esophagitis and the current unmet needs and the current management of these two diseases which form the spectrum of the same adverse food reactions. Will biologicals fit in this script of the unmet needs of both the current management practices? So, the spectrum of food allergies, especially in the immune-mediated, as we all know, includes Ig-mediated, non-Ig-mediated, delayed reactions, and mixed disorders. I seldom touch base upon mixed disorders in my presentations mostly. We would be mainly highlighting on the IgE-mediated because we are all worried about the severe Ig-mediated reactions, which could be anaphylaxis on one spectrum, or the non-Ig mediated spectrum, which has no supporting tests, unlike the Ig mediated, like the skin prick test or the serum specific IgE or biomarkers. Also, as we were hearing from our earlier speakers, I think the mixed type is a little not much dwelt upon very commonly. The estimated prevalence of food allergies in the recent past has grown due to a lot of variable factors such as westernization of our diets, and earlier recommendations of delayed introduction of allergenic foods, which has seen a major overhaul in the last decade or so. So milk and egg allergies are more common in the children, which tend to be outgrown in most of the children by school-going age group, whereas nut allergies and tree nut and shellfish allergies tend to be a little more commoner in the adult because it is persisting and unlikely to be outgrown. In the Indian context, we have Europrevol study, which gives the sensitization rate under close to 0.2%, and sensitization rates much higher than the actual food allergies. As we all know, most of the foods like milk, egg, wheat can be outgrown, and children who are having food allergies, at least up to 50 to 80% of them could be allergic to multiple foods, okay? And in the spectrum of food allergies, eosinophilic esophagitis and pollen food allergy syndrome usually tend to persist into adulthood other than the other foods we have mentioned. Coming to the spectrum of mixed IgE and non-IgE mediated food allergies, the terminologies which very commonly is used is the primary eosinophilic gastrointestinal disorders, that is EGIDs. And characteristically, they are characterized by the eosinophilic infiltrate in the gastrointestinal tissue in the absence of any other demonstrable cause. Mainly, it's a disease of exclusion. And then when we are thinking about it, then we go on to get a biopsy done and confirm the diagnosis. The presentation of EGIDs vary based on the anatomical structure of the gastrointestinal tract which is being involved, and also vary by the age of the patient. In younger children, it could be mainly presentation with vomiting, nausea, abdominal pain, failure to thrive, very non-specific. Older patients, it could be weight loss, dysphagia, and food impaction. So in EGIDs, I think there are specific newer nomenclature based on the anatomical part which is being involved, including eosinophilic esophagitis, eosinophilic gastritis, eosinophilic enteritis, and colitis. And more than 2 areas concurrently being involved. Very commonly we see eosinophilic esophagitis and EOG, that is eosinophilic gastritis. Why eosinophils in the lower GI tract are common, generally because, especially in the lower GI tract, unlike the esophagus, they are the resident cells in the lower GI tract, and they play a role in the general mucosal immunity of the gut. If there is an increased in the tissue eosinophils from the normal, generally likely is reflective of this eosinophilic gastrointestinal disorder based on the particular anatomical part which is being included. Mainly coming to the eosinophilic esophagitis, it's a chronic type 2 immune-mediated inflammatory disease of the esophagus. And clinical complications generally we see because of the esophageal rigidity which is associated with the anatomical defects. I will be covering this bit in the next few slides regarding the clinical progression and what is the pathophysiology which could be involved in EOE. We all know this eosinophil thresholds for EOE as well as other non-esophageal EGIDs. Mainly this was from a review paper published last year. So as we all know, in the esophagus, if it must be considered abnormal, it must be more than 15 eosinophils per high power field from the biopsy report. And we see it increases lower down in the gastrointestinal tract. Stomach, it is more than 30. And mainly in the ascending and descending colon, it is anywhere between 80 to 100. Because as we know, eosinophils form the resident cells in these mucosa in this part of the gastrointestinal tract, and the numbers tend to be a little more higher as compared to the other parts of the gastrointestinal tract. So basically, when there is eosinophilic infiltration of the gut epithelium, this leads on to Th2-driven remodeling and fibrosis, which leads on to angiogenesis and smooth muscle hypertrophy. This causes mainly the strictures and anatomical defects associated with eosinophilic esophagitis, as we all see. What are the main inflammatory markers? Here we see, because in food allergy, it is mainly IgE mediated, right? And to a very lesser extent, the other interleukins come into play. Whereas in eosinophilic esophagitis, it is mainly type 2 inflammation, and because of the barrier epithelial defect, which is more common in atopic dermatitis, which is also a mixed disorder, EOE also, I think it is mainly driven by the Th2 differentiation, mainly mediated by IL-4, interleukin 13 and 5, which mainly drive the type 2 inflammatory effects, what I was describing earlier in the form of fibrosis, increased smooth muscle hypertrophy, and barrier disruption. So based on this interleukins involved, the biologics also are mainly chosen accordingly because of the pathophysiology being involved. Again, a word of caution, because many of the mimics of an eosinophilic gastrointestinal disorder, again, is non-Ig mediated because the history is a little more non-specific. Non-Ig mediated triac diseases can be triggered by foods, often dairy, soy, or rice, or oats, but also many other foods. And FPIES is an earlier presentation in acute, could be like a sepsis-like picture. If it is a chronic FPIES, could have failure to thrive, vomiting, diarrhea, and a not so easily consolable infant. Food protein induced proctocolitis generally resolves by 1 year of age, whereas this can persist. EOE can, or EGITs can persist. Other than IL-4, 5, and 13, also there are certain other cells which could be driving the Th2 pathway. It could include TGF-beta, TGF-alpha, and CCL26 and CCL11, which are the primary chemotactic factors. So having dwelt into the basics of pathophysiology and probably the difference in the clinical presentation, the current management strategies are quite different for both these conditions. Food allergies include allergen avoidance, as we all know. If we have been able to demonstrate the sensitization and clinical relevance by second history, allergen avoidance still remains the norm in IgE-mediated food allergies. And if the patients had had an anaphylaxis secondary to the food allergy, we would manage with anaphylaxis action plan, educate them about epinephrine usage. And if patients who have had anaphylaxis and the possibility of them outgrowing these food allergies are less, then we may choose about oral immunotherapy based on the patient's clinical manifestations. What about EOE on the other end of the spectrum? Mainly it is a dietary elimination of that particular suspected food, proton pump inhibitors, topical corticosteroids, mainly budesonide, which can be quite variable. Uniform absorption is a little challenging. And in India, we do not have oral budesonide, which is approved by the FDA in the US and in certain parts of the Europe. So we still rely upon the budesonide, which we get as for the nebulization. And I've had very handful of patients who are on EOE and requiring topical corticosteroids. So the clinical resolution or response to the topical corticosteroids is very variable and subject to a lot of other factors. And esophageal dilatation, if it is structure or anatomical defect has happened, as we were discussing earlier. It comes with its own limitations because it's a burden of the dietary restrictions, which is associated with both these adverse food reactions, risk of micronutrient deficiencies, because we're taking away those foods. And if we do not involve a dietitian, they are definitely at risk of nutritional deficiencies. Variable efficacy of topical steroids, long-term poor adherence. I think especially it is hold goods for EOE. and there is no curative treatment yet for both of them. I think that's where the biologics come into picture, where can we contemplate reducing the severity of the disease for these patients. And mainly, I think there is a lot of little similar inflammatory molecular mechanisms which exist along the same atopic spectrum. So I think the biologics in the arena of food allergies and EGIDs is quite interesting, because when I was going through the literature for the preparing, there is more than 30 ongoing clinical trials. I think in the next couple of years, it is quite interesting to see how biologics can improve the quality of life of patients with food allergies and EGIDs. So just to highlight, because on the left side of the slide is the immunopathology which is involved in food allergies, and where the biologics can be used accordingly, which is encircled. Mainly it is mast cell mediated or basophil. And again, we see IgE, anti-IgEs are many, and dupilumab, because the B cell could have been influenced by IL-4 and IL-13 as well in the production of the specific IgE for that particular allergen as well. So I would be probably highlighting on these two biologics in the management of food allergies. Subsequently, even though we do have other MABs such as etoquimab or IgE disruptors such as tezepelumab, or on the right side of the slide is mainly for the EOEs, where it is the pathophysiology is entirely different, and dupilumab, because it has an anti-IL-4 and 5 action, as well as other biologics such as mepolizumab or bernalizumab. So this slide I had just put up to highlight that biologics have been in the arena since the early part of the century, but I think the momentum has hastened since the last decade or so, where it has been, because it is a same spectrum of the atopic diseases. If it is indicated and works well for other atopic diseases, such as we were hearing from Dr. Vijay Bharat sir regarding the other indications which biologics were used, why can't it be explored for food allergy was the question. And I think in the recent past, a lot of work has gone into the role of biologics in the context of food allergies. So omalizumab in 2021 has been approved as a pre-filled syringe across all indications, including severe asthma, chronic urticaria, food allergies. And dupilumab became the first biologic in 2022 to be approved for the eosinophilic esophagitis. So mainly omalizumab, I think the biologics in the food allergies, I think a lot of work has been done, and safety efficacy is mainly on the omalizumab. Though the next generation anti-IgE, which is ligizumab, which is the next generation high affinity anti-IgE, and it is ongoing clinical trials which has been ongoing, and talizumab. Okay, so these are the anti-IgEs which are being studied in the context of food allergies. I would put a little bit data on dupilumab with which I could gather. So as I was telling, I think, so these are the anti-IgE MABs, which are, the ongoing studies are there already. And let us take it up one by one. So the most safe and approved drug in the context of food allergy is omalizumab. Several phase 2 and phase 3 studies have shown the adjunct effect of omalizumab to improve the speed and efficacy of desensitization to single or multiple foods when used in adjuvant to as in the oral immunotherapy. I personally have used omalizumab in my small subset of patients who underwent OIT, especially because oral immunotherapy, sometimes we are, the main limitation factor is the gastrointestinal adverse events. And sometimes it is very difficult to step up the dose to in the maintenance dose. And because of the adverse effects, we may not be able to move forward. And omalizumab increases the threshold for us to overcome these adverse effects and help in moving forward with the desensitization. I think the most common approach, because it has also been well studied in the asthma-based and urticaria dosing, even though there has been 2 weekly to 4 weekly dosing, I think monthly dosing has, again, like for other atopic diseases where it has been indicated, it has been shown to facilitate desensitization to multiple foods. I think this was one of the landmark study in the recent past. And phase 1 of the outmatch study was published in New England Journal of Medicine just last year. So outmatch study, basically it is a prospective omalizumab phase 3 study which enrolled patients from 1 to 55 years of age with multiple food allergies for a period of variable period. Phase 1 was mainly omalizumab, which was used alone. Phase 2 would be omalizumab in adjunct with multi-food oral immunotherapy. Phase 3 is to study the feasibility of these patients who have received omalizumab with food allergies to switch over to real-time food equivalents. So phase 1 has been completed, and this was the results, which was quite exciting. So the cohort which received omalizumab found that 2/3 of the patients could consume up to 1000 mg, which is a sizable amount of the portions for that particular individual of peanut, egg, milk, walnuts, or wheat. And mostly, I think it gave good protection for them to have these foods. At least on accidental exposure, they wouldn't develop anaphylaxis. So it is interesting to look out for phase 2, where using in addition to multiple food OIT would be interesting arena to look out for. So in the recent past, in the last 2 years, omalizumab has been approved by the FDA for children above 1 year and older with allergies to multiple foods, one or multiple foods. Again, it has to be used in conjunction with food allergen avoidance measures. It cannot be a standalone therapy and cannot replace epinephrine, and should not be used by individuals who have had a history of hypersensitivity reactions to omalizumab in the past. I think this is going to revolutionize the management of food allergies along with OIT. Now coming to, so other anti-IgE was legislumab. I think the phase 3 trial is ongoing with monotherapy for patients who are receiving multi-food OIT from 5 to 66 years of age, and it is ongoing. The results are probably expected in the next 3 to 4 years. And talizumab, I think 450 mg is recommended about 12 years of age. Again, phase 2 trials are ongoing. Interesting arena to look for if it can replace omalizumab. Coming to dupilumab in food allergy. So it is anti-IL-4 antibody receptor. The indicators for dupilumab again are many, like omalizumab, moderate to severe asthma, atopic dermatitis, chronic rhinosinusitis. But as a person who's interested in food allergies, for me, I think the main thing was getting an indication for usage in patients in adolescent and adults for eosinophilic esophagitis, because it has a action on the IL-4 receptor A, which is the receptor for pro-atopic and cytokines such as IL-4 and 13, also making it an ideal target like in other allergic diseases, which also includes food allergies. I think the dupilumab is being explored mainly over its added advantages over omalizumab, because it has a wider impact and a wider outreach for other interleukins rather than just anti-IgE alone. So in the context of immediate IgE mediated reactions, the patient had, this was an ongoing, adjunct treatment with OIT is currently being examined in phase 2 clinical trials, of which results are awaited. Okay, so this is mainly standalone and also in conjunct with OIT is being studied. Other modalities which are being mooted is also anti-JAK, anti-Bruton kinase inhibitors, which are ongoing and results would be awaited. Now, coming to biologics in the context of eosinophilic esophagitis, dupilumab has been approved, though other mAbs such as benralizumab, mepolizumab are being in clinical trials. So, this dupilumab has shown to reduce eosinophilic inflammation with the reduction in the histologic and endoscopic features, which is very characteristic in patients with EOE after treatment as versus the placebo group. So definitely, I think this has paved the way to study its role in other non-EGID disorders such as eosinophilic gastritis and other eosinophilic gastrointestinal disorders. Anti-IL-5 reslizumab, I think this is an ongoing. The results were quite mixed, though they found that the histological reduction of eosinophil counts occurred quite significantly. However, clinically, it could not be translated into practice because there was no difference in the physician EOE assessments between the treatment groups. Mepolizumab, again, there was no difference in the symptomatology, even though there has been evidence to see the reduction of the eosinophilic infiltrate on the endoscopy as well as in the histology. I think it's too early to talk about this. And there is ongoing phase 2 clinical trial, which is seeing with an increased dose of mepolizumab, which found that there was no difference in the symptomatology. If the higher dosage comes out with a good clinical response, I think this could be also one of the mAbs which could be considered in the eosinophilic esophagitis. So along with other IL-5 and IL-5 receptors, what we were talking, there are few of other IL-13 which is being mooted. So benralizumab, I think also there was a small cohort of patients which received with hypereosinophilic syndromes, which also involved the GI eosinophilia. They have reduced GI eosinophils, but more phase 3 trials are ongoing. I think all in all, there are a lot of benefits because it's a targeted therapy, improves the quality of life. Again, depends on, we have to think about the cost, especially in our country. Omalizumab is easily dispensed in the US and the Europe for the patients to receive, inject by themselves at home, reducing the cost as well. Also, there is, the data till date has been quite safe about long-term safety efficacy. I think as we get more data from the ongoing trials, it would be interesting arena to look out for. So I think we are moving forward towards personalized medicine with the biomarkers, combination therapy, and especially the translation from the adult and the adolescent practice coming into the lower pediatric age group as well. So there are a lot of questions also in the context of food allergies and biologicals. What is the optional dose, timing? Can we use this two or one or biologic, more than one biologic? How can we track the effectiveness of the biologic? Can we use the biologics along with OIT, or this biologic would be still good enough? And how long would the benefits of biologics vary? So I think there are answers also to be these questions, and I think with time, with the ongoing trials, we would be getting the answers for these questions. So I think biologics would be definitely the main, has a promising potential in the management of patients with food allergies and eosinophilic esophagitis. Thank you for a very patient hearing. I'll be happy to take up any questions if
So thank you, Dr. Soumya, for such an informative talk. And we do have some questions. So I was just thinking, can we differentiate, or I was having I had just read in an article in Pediatric Journal that can this PPI or budesonide inhaler therapies be used as a diagnostic criteria for eosinophilic esophagitis? Because many of the time, patients, small kids, they don't want to undergo an endoscopy.
A very good question and a practical question, Dr. Tina. I think if we are, because most of the times it's a disease of the diagnosis of exclusion. I think if we are strongly suspecting and the clinical trial of with this pharmacotherapy may be very biased. So I feel involving our pediatric gastroenterologist and trying to get a biopsy who are experienced in even with the pediatric population, I think would be will be answering the questions long term, because also of the disease spectrum to be involved for a longer period of time. So I think a diagnostic endoscopy would be definitely worthwhile getting it done if the clinical suspicion is quite high.
So, and another for the convenience of all and for just learning sake, can you advise, describe the technique of use of this budesonide inhaler in esophagitis, because still we don't have oral budesonide available in India.
So generally, we may ask to tell them to take our regular budesonide inhaler, whatever we have, without the spacer, and hoping that the deposition can happen in the upper GI tract. And we wouldn't tell them to gargle, like we advise them for our patients with respiratory airway allergies. Sometimes also few of our my seniors have inculcated the use of the budesonide respules also, which we use for nebulizations. I think that's more in the liquid form, and probably that could be the outreach to the lower esophagus is far more better than using the budesonide inhaler is what hypothesized. But it is a very crude way of using also. So right now, the patients whom we manage with the pediatric gastroenterologist with EOE, they tend to use this budesonide respules. Okay. So very variable response
You
again.
have to use this respules through mouth, no? There is a mouthpiece, and through that
Yeah.
mouthpiece, they are
Yes.
supposed to.
Yes.
But that leads to lots of ulceration and inflammation
Correct.
in the oral cavity.
Correct. Correct.
So one more question Dr. Neeraj has put up. I think a very genuine one. I also had this doubt in mind that this total IG, would that be a guideline for your treatment with omalizumab in food allergies as well, like we have in respiratory allergies?
I think, see, for me, in the context of food allergies, we know that we have a sensitization pattern and we know that it's an IgE-driven disease. I think probably it may just give us more confidence that omalizumab is going to work because the total IgE may be higher. But other than that, I don't think this serves as a yardstick for the disease duration, for the duration of which we are going to use omalizumab, or the response to the therapy, or the regression of the clinical symptoms. So I don't think it would be of much clinical relevance like other IgE-driven diseases.
Another one is that this omalizumab with economical biosimilar with limited efficacy against dupilumab. So dupilumab is definitely expensive. So do you have any head-on-head data or experience, or what is your take on that?
Dupilumab, I have not used personally in the context of food allergies. And I think we do not have access to dupilumab, I mean, directly also.
Yeah.
I think omalizumab, even with the biosimilars which we have access to, has given good clinical response when I have used in patients with our food allergies who underwent OIT, and we could increase the dosage of the maintenance where they had reactions and we couldn't updose. So for now, I think omalizumab and the biosimilar is working just fine. Though I think as we are seeing more data emerging, hopefully we have more access to these biologicals and for use of patients with food allergies in our country.
Thank you so much, Dr. Soumya. It was really once again very nice hearing you, and you've taken such a difficult topic in a very nice and lucid way. Thank you so much.
Thank you for having me.
And
Very nice moderation, Dr. Tina. Thank you.
Thank you. So moving ahead now, please be glued to the seats who are watching us live on YouTube, because we have another important topic and a very eminent speaker, Dr. Ankit Parekh, who is a senior consultant and head of Department of Pulmonology and Allergy Specialist at BLK Max Hospital. And he has an extensive role in using biologics in refractory asthma. So I would like to invite you, sir. Welcome, sir. Good evening. And please tell us about what to be used and what are the latest GINA guidelines and your special experience with the use of biologics in asthma.
So thank you, Dr. Tina. And I'll just share my presentation. Okay, so I hope the slides are visible.
Yes, sir. Slide is visible. It's very clear.
Okay. So good evening, everyone. And thanks to the allergy chapter and Dr. Neeraj for inviting me for this talk on biologics for severe asthma in children. So what we'll try and do in the next 20-25 minutes is to discuss about how do we approach a child with severe asthma, and we'll try and figure out that how do you reach to a point where you decide that this is a child who possibly needs a biologic therapy, and the next step is that how do you choose that biologic therapy which this child needs. So we'll briefly talk about phenotyping, because without phenotyping, you can't match your child with the biologic which he requires. And we'll briefly talk about biologics, its indications for asthma, the age of approval. And I'll briefly share with you what is our experience at BLK Max Hospital. Right, so we start from the GINA guideline table, and if you look at the table for 6 to 11 years old or adolescents and adults, we are basically looking at a step 5 treatment, right? So we are talking about a child who is on moderate dose corticosteroids with additional 2 controllers. One of them is obviously a LABA. The second one could be either a montelukast or a derifylin, or it could be a LAMA, which is your tiotropium. So if a child basically fails this, then that is a step 5 child who needs to be worked up for biologic therapy, right? So that's the entry point for the algorithm which we are talking about. Now, what we need to understand before deciding biologics is that if you have a child who presents to you with symptoms and who is at getting step 4 treatment and not getting better, and someone has referred the child to you, then it falls into a category of what is known as an uncontrolled asthma, right? And this uncontrolled asthma can have different reasons. So not all patients with uncontrolled asthma are candidates for biologics. And the most important cause of a child who presents to you with an asthma which is not well controlled is this. So it is usually a combination of something known as difficult to treat and asthma plus. So what these mean, these entity means are that difficult to treat is a child who is not getting better because he is not getting the drug properly. So which includes problems with inhaler compliance, adherence. It also includes technique. It also includes allergen exposures, avoidance of triggers, right? So these are the usual factors which you have to look at. And until you have taken all these factors into consideration, you cannot go on to the next step, right? And in addition to that, most of these children will be having comorbid conditions which have not been identified and treated. And that is also a reason why that this child's asthma is not getting controlled. And in majority of patients, you find a combination of these. So they have some factors which which are leading to difficult to treat, as I've told, and there would be some comorbid conditions, and treatment of these two together would improve more than 95% of your patients, right? So that's something which we have to look at. The second thing which you have to look at is not asthma at all, which means that a lot of patients who present to us at step 4 failure, wanting step 5 treatment, would be having an alternate diagnosis, right? And that is something which we have to carefully look at. The diagnostic entities could be things like, the most common being suppurative lung disease, which has not been picked up. And unless until you look at these children carefully, you can miss things. Cystic fibrosis, primary ciliary dyskinesias, bronchopulmonary aspergillosis, tropical pulmonary eosinophilias. These are common differentials in an older child. But you can also have things like a vascular ring which has been missed. You can also have patients with tracheobronchomalaccias which have been missed. And these are presenting like severe asthma, but they are not. So all that wheezes is not asthma. And a good understanding of these differential diagnoses and how do you need to work up these differential diagnoses is extremely important, so that you are able to reasonably exclude these differential diagnoses before moving on to the next step. And then what you are left with is a small group of patients, which we will talk about today. And these are patients who are defined as a therapy-resistant asthma, where you need to evaluate these children further, phenotype these children further, and consider using a biologic agent. So when a child comes to an asthma clinic who is poorly controlled, this is the way most pulmonologists would be doing. So they would first confirm the diagnosis. So a reasonably good history and examination with some basic investigation can be very helpful. We're not trying to say that all patients with severe asthma requires a bronchoscopy or a CT or a sweat chloride and so many things. No, it depends on a case-to-case basis. A good quality lung function, a good quality spirometry showing obstruction and reversibility is something which is very helpful, and should be done at this point of time if it has not been done previously. Because if you can document clear obstruction and reversibility, then most of these differentials are actually out. They can still be comorbid conditions. That's a different issue. So step 2 is that you're looking for contributing factors to symptoms. You're looking at exacerbations and quality of life. You're trying to see what amount of oral steroids they are getting, how much, how many hospital admissions are happening, how many PICU admissions are happening, how much amount of school absenteeism is there. So broadly, we are trying to look at the quality of life of this child. And then what you're trying to do is simultaneously talk to the family about asthma. Most of them don't understand what asthma means. Believe it or not, more than 90% of patients have their technique wrong. They're not adherent to treatment. The comorbids have not been treated properly. And at this point of time, you can consider doing a step up of treatment if it has not been done previously. So give time to this patient. Using a biologic is not the first thing which we'll do. We keep this patient under follow-up for a few months, usually for a period of 3 to 6 months. And if this child still remains uncontrolled with everything else which we are trying to do has been optimized, only then I would label this child as a possible therapy-resistant asthma. And at this point of time, you're trying to phenotype this child, or you can phenotype this child previously as well. During the 3 to 6 months to be, not wasting time thereafter. But phenotyping is basically required at this step. Now, what we basically do for phenotyping at the moment is doing an exhaled nitric oxide and measuring eosinophils in the blood. You're also trying to look at the allergen sensitization with either an SPT or immunocap or both. Sputum eosinophils is more of a research tool and is not very easy to do in clinical practice. Some centers also do, for example, Brompton, which is a quaternary center for asthma care in the UK. As a part of their protocol, they might be doing, bronchoscopies, BAL, and even endobronchial biopsies to look at the asthma phenotypes. But most centers will not be doing that as of now. Bronchoscopy might be required to look at alternate diagnosis. It might be required to take a BAL sample. So that is another help which you might get by doing a bronchoscopy at this point of time. Now, once you have done that, you're trying to phenotype, you're trying to look at what pattern of inflammation do you find, and the most common being a type 2 inflammation or a T2 high asthma, where the blood eosinophils are high, your phenos are high, and asthma appears to be clinically allergy driven, and there can be atopic markers as well. So these are the biomarkers, as I've said, we use in clinical practice. Blood eosinophil count and FeNO are the commonest. Airway sampling and sputum induction is not something which is commonly done in clinical practice. Obviously, all these biomarkers have their own benefits and limitations. Both of them are easy to measure. They are thought to be surrogate markers of airway eosinophilic inflammation, but there are lots and lots of factors which can be a problem, especially in the pediatric age group. And one of the problems which you find is using oral corticosteroids. So sometimes if children are using oral corticosteroids, the response gets suppressed, and you actually feel that they are T2 low, but they are not actually T2 low, they are T2 high. And hence, a lot of societies have recommended that you try and repeat these biomarkers at least 2 or 3 times during the course of treatment to look at the asthma phenotype. And then you try and see, what phenotype this child would fit into. The most common would be an eosinophilic asthma, which is atopic, right? So that's the commonest thing which is found in children with severe asthma. So eosinophilic asthma with allergic inflammation is something which you will find. But there is definitely a group of patients with asthma who seem to have a T2 high asthma, but they are not having any positive perennial allergen, and possibly their eosinophils are higher and their FeNO is higher. So this is a group of asthma who is T2 high, but it is possibly not driven by an allergy, and that phenotype is not as common in children as in adults. And I'll just talk about these phenotypes in the next few slides as well. But people have described, the other phenotypes like non-eosinophilic asthma, which can either be polygranulocytic, where you don't find a lot of cells in the sputum induction or in the BAL. And in histologies, you can have a mixed inflammation or a mixed granulocytic asthma as well, and they fall into the T2 low variety. So the asthma endotypes, as I said, they could be T2 high and T2 low. The T2 high is predominantly an eosinophilic variety. It can be allergic or non-allergic or non-atopic. Usually the age of onset is a bit early. The FeNO levels are higher. The sputum is predominantly eosinophilic, and there's a good response to steroids. On the other hand, T2 low is usually neutrophilic or polygranulocytic. They're usually later in life. This variety is uncommon in children. The FeNO levels are normal, the neutrophils are predominant, and the response to steroid is not good. Now, if you look at the eosinophilic variety or the T2 type asthma, it is usually divided as atopic and non-atopic. And atopic is something which is commoner in the pediatric age group as compared to the non-atopic variety. Early age of onset, a perennial allergen which is positive, an IgE which is high, presence of rhinitis, presence of a high FeNO, and eosinophils which are not too high is the usual hallmark of an atopic asthma as the commonest variety. But there's a group of patients where they're slightly older, you don't have an SPT or your allergens positive, your IgEs are low, and the phenos are quite high, and the blood eosinophils are quite high. So these are markers of an eosinophilic asthma, which definitely exists in all age groups, but it is rarer in pediatrics. Now, what we also need to understand is that these biomarkers, they are, it is easy to talk about these biomarkers in a table, but what people have found is that, all these biomarkers sometimes don't gel together. So you may not have, phenol high in all patients or eosinophil high in all patients, or allergen sensitization, which is high in or positive in all patients. So this Venn diagram actually is very interesting, which tells us that patients who are T2 high, a lot of them can have just an allergen sensitization. A lot of them can have a pheno which is positive. A lot of them can have blood eosinophils which are positive as an isolated entity. Many of them can have two biomarkers which are positive. There's a group of patients who can have all of them which are positive, right? So you need to, carefully look at these patients and as I said, repeat biomarkers 2 or 3 times at least before you conclude that it is a T2 low asthma, because that is something which is a rarity. There has been a lot of literature also on switching of phenotypes or converting into mixed phenotypes. So initially it is T2 high, but as age progressive, a lot of factors which actually pushes a child from a T2 high to an adult type of asthma, which you see in the adolescent age group as well, where it becomes, not just allergic, but also non-allergic phenotypes. And that is a problem to deal with at this point of time. Now, just a small caution about T2 low asthma in children. So the question is, how do you define it? It is basically by a negative biomarkers. Some people might look at neutrophils in the sputum, but it is not very easy. And airway biopsies or endobronchial biopsies are rarely done. Now, there are major issues which have to be kept in mind. As I said, concomitant treatment with oral corticosteroid leads to a lot of confusion. Try and repeat your biomarkers. The most common reason of a T2 low asthma in children is basically an unrecognized suppurative lung. Right? And so if you find a child where your biomarkers are negative and this child doesn't seem to respond to treatment, before going on to any further step, very carefully look at alternate differential diagnosis, which leads to a predominant neutrophilic response or a T2 low sort of a picture, which mimics an asthma. And this could be primary ciliary dyskinesia, cystic fibrosis. In India, we get a lot of idiopathic suppurative lung disease or sometimes post-pneumonia, post-TB type of bronchiectasis. But there's a group of children who have an idiopathic suppurative lung disease which has not been picked up. And in these situations, doing a bronchoscopy is a very good idea. And in many of these patients, what we have found is that they have bacterial colonization, even sometimes pus in the airway, which has not been recognized. So it is a missed suppurative lung, which is more presenting like a T2 low asthma. Look for GRD. Look for chronic aspiration, which can be there, and also look at vaping and smoking, especially in adolescents, which is becoming a newer trend. Now, what we know about phenotypes of severe asthma. Now, we don't have a lot of data from most countries, but what is there is the two large cohorts of severe asthma in the world which have been followed up. One is the U-Biopred cohort from the European countries, and this article was published in 2015 by the Brompton group, by the Andy Bush group. And what they found was, as written in the lower part of your slide, that most patients with severe asthma, they are actually having a phenotype which is more of atopic. Now, what we don't know is that are children or Indian children similar to the European cohort or the American cohort, because in India, at least 30, 40, or 50% of patients with asthma are actually non-atopic. But I don't think that we have a lot of data in India on severe asthma in children. We don't have a registry for that as well. But the understanding throughout the world tells us that it is more of an atopic variety than of a non-atopic variety. So that is what we understand. And there's a large SARP cohort or SARP3 cohort, which has been from the bariatric group, which also shows similar findings that most of these patients are actually atopic and they are T2 high. What they also have shown is that, severe asthma in children can be a bit different prognostically as compared to adults. And if you look at this, this blue and green picture here, what it tells us is that the green one is the non-severe asthma and the blue one is the severe asthma. And if these children are followed up, so this is a 3-year data which they have shown that, what happens to these patients. So what they have shown is that a lot of patients switch from a severe asthma to a non-severe asthma, right? So there's a lot of switch. And when these patients were followed up, almost 60% were having severe asthma at the start of therapy or at the start of the study. And you can see that this went down approximately by 50%, and there were 30% patients which were still having severe asthma criteria at year 3. So prognostically, in children, severe asthma is not as bad as in adults. And this is what has been shown in the SARP3 cohorts. So we come back to the approach. So you're trying to look at the phenotype, and if you have an eosinophilic phenotype versus non-eosinophilic phenotype, so what options do you have? Obviously, using a MART therapy at this point of time can be something which can be helpful. And it has shown to have utility at this point of time. And if you compare using, for example, an inhaler which contains budesonide formoterol, 200 micrograms, 2 puffs twice a day for a child, and SABA versus using a MART that is using an additional doses of ICS LABA. And at this point of time, at least, step 4 patients do better on MART. You can reduce the amount of oral corticosteroids which they have used, and there is data about that. So we don't use MART for most of our patients on step 2, step 3, because of a lot of reasons which we can discuss later. But at step 4, using a MART therapy can be a good option. So daily defined doses of ICS LABA and additional doses, or if they have some symptoms in between, then early increasing the dose can be quite helpful. Some people would go even to higher doses. So supposing you have a child who is less than 10, 12 years of age. So the moderate dose is something like 400, but some people would try 800. And older children where moderate dose is like 800, some people might try 1200 and 1600. Although it has been seen that the dose response curve actually plateaus at somewhere between 400 and 800. But obviously, there's a group of patients who might be helped with that, but be careful. Our lives have become quite easy after the availability of tiotropium approximately 6-7 years back. And this tiotropium step up, which is a non-biologic step up, has made, at least our lives very easy, because a lot of patients who were actually candidates for biologics get well controlled with tiotropium if used properly. Obviously, you're trying to look at the other comorbid conditions and things which we have talked about. And as I said, that if you have a non-eosinophilic phenotype, look at the other factors, try tiotropium. I would definitely do a CT chest and a bronchoscopy in this group of patients, especially if they are T2 low, because I'm really worried that I'm actually missing a suppurative lung disease, which happens most of the times. Now, if you have a T2 high patient, what are you going to do about it? So, most of the times, the discussion will come back to cost. And we understand that, it is neither available in most of the institutions, the government institutions. It is not available even by the insurance companies. So basically, the cost is prohibitive and most patients are going to pay out of their pocket. Uh, uh, what are you going to do about these patients? So what we tend to do is that we have said that, you use 2 additional controllers in the form of inhaled corticosteroids and additionally use 1 more controller, either montelukast or LAMA, which is tiotropium. But most of us, before going on to the biologic step, would keep these children for some time on at least, if not 2, you can keep them on 3 or 4 more controllers, which includes using montelukast in proper doses, not low doses that a lot of people would do. So 10, 5 or 4 depending upon the age. Using tiotropium properly, and in some patients we do add derifilin as well. So usually if a child would fail even this, then we try and switch them on a biologic. So if you're talking about a biologic and you have spoken to your family, then you come on and decide that what you need to do. So I think this has already been discussed, and just to reiterate, the most commonly used biologic is omalizumab, which is your anti-IgE. But you also have neobiologics, which are now available, and their age of approval has come down. So omalizumab is 6 years. Mepolizumab is again 6 years. It is an anti-IL-5. You also have benralizumab, which is anti-IL-5R. Now the age of approval is 12 years, which was previously 18. And then you have dupilumab, which is anti-IL-4 and anti-IL-13. Now, what we don't have at the moment is tezepelumab, which is an anti-TSLP, which can be a good, biologic for some category of patients, and we'll talk about it. So this is the age of approval, as you see here. We have omalizumab available, we have mepolizumab available, we have benralizumab available. Dupilumab is, I have not used dupilumab because of the cost and the availability as well. Tezepelumab is something which is not available to us. Omalizumab has a lot of indications even other than asthma, and I'll not talk about these in this talk because we're talking about only biologics for asthma. But it is the atopic variety, T2 high atopic variety, which children are candidates for omalizumab. Eosinophilic asthma, it is more of mepolizumab and benralizumab. Okay. So this is the way you try and choose your biologics. So as a simple rule, what we are looking at is, so if you have an SPT or immunocap which is positive, in a child where your IgE levels falls between 30 and 1500, that is a child who is possibly a candidate for omalizumab. If your SPTs are negative, your IgEs are low, but your eosinophils are high, that is more of an eosinophilic asthma, which is non-atopic, and the choice remains as mepolizumab or benralizumab. Anti-IL-4R is definitely more expensive, and as I said, availability is a problem. It can be used for patients who have eosinophilic asthma, and especially if they have comorbid condition of atopic dermatitis, because this is a drug which is very useful and used worldwide for atopic dermatitis in children as low as 1 year of age as well. Now, there are off-label use of omalizumab, and there are few children where we have used it as well. So there are clinical situations when your IgEs are higher than 1500. There are children where, they appear to be clinically atopic. Their IgEs are high, their eosinophils are not very high, but somehow their SPTs or serum specific IgEs are negative. And there is data and clinical experience to suggest that omalizumab can be useful in these children as well. And you have children under the age of 6 which appear to have a severe asthma. They're possibly atopic, but the age doesn't match. So these are off-label use of omalizumab. So non-allergic asthma and most pulmonology centers who cater to children with severe asthma believe similarly that if your SPTs are negative, or your serum specific IgEs are negative, this does not mean that this asthma is non-atopic. Possibly, there can be a situation where you're not able to identify an allergen. And depriving this child of omalizumab is not worth it. And in few of our patients as well, we have seen similar things. So omalizumab can or should be tried in patients with severe uncontrolled asthma, even if you do not have a IgE specific sensitization, which is there. People have used it for IgEs which are higher. So what do? Is you use the top dose, which in the Indian setup being 300 milligram every 2 weeks. We don't have a 75 milligram vial available. So we usually use 2 injections, 150 milligram in both arms, and we do it every 2 weeks. So that's the top dose which you can use. And again, as I said, we don't have a lot of RCTs or meta-analysis available, but you definitely have real-world evidence which talks about it in the adult world and in the pediatric trials, that omalizumab can be useful in this condition as well. This is a trial which is ongoing, known as a PARC study of preventing asthma in high-risk kids under 6, which is looking at using omalizumab in under 5 children or under 6 children. And I hope that we'll get the results soon and then we can talk about these. But definitely, again, if you have a phenotype which is very clear, only the age is the issue, then you are absolutely justified in using omalizumab in such situation as well. A lot of people, including us, we use omalizumab with the AIT, not just in the context of reducing the side effects of immunotherapy. So if you're using it for subcutaneous immunotherapy, you're trying to reduce the adverse effects like anaphylaxis or severe local reactions with omalizumab. But what we are doing more is to make a child from poorly controlled to well controlled with omalizumab and then add immunotherapy, because immunotherapy is something which can possibly be disease modifying. You cannot continue omalizumab for not many years because of the cost and the subcutaneous injections. But if you use a combination of omalizumab with immunotherapy, and if you can turn this asthma from severe even to a moderate one, then you markedly change the quality of life. You can stop your biologics. The immunotherapy can go on. And this child, even if you are able to step this child from a step 5 treatment to a step 3 or step 4 treatment, that's good enough. So we are not looking at complete cure of asthma. That's not the aim. We are looking at reduction in treatment or reduction in steps of treatment. Although we understand that we don't have a lot of data as of now in the pediatric age group. Okay, so we have used omalizumab in few of our patients. So we have around 8 patients who are in active follow-up where we have used omalizumab, and these are the indications which are there. And as I said, how do we choose our patients might be slightly different as compared to the Western world. One of the patients has asthma with a steroid-dependent ABP, and the rest of the were asthma with or without rhinitis. So usually, we would do it this way, that we use ICS moderate doses with LABA, at least LAMA, because our experience is that using tiotropium at this point of time is extremely helpful. A lot of patients get well controlled with tiotropium and don't need to step up. So that's the way we do it. If they're not still doing well, you try and add montelukast, you try and add darifilin, and during the meantime, you're trying to prepare their mind for the next step of therapy and doing the phenotyping simultaneously. So this group of patients, especially if they have frequent exacerbations requiring oral steroids or they're steroid dependent or have multiple hospital admissions, are the usual candidates. And obviously, you are looking at lung functions as well. Okay. So this is the distribution of treatment. So most of these patients were on high dose inhaled corticosteroids. All of them were on LAMA. almost all were on montelukast, some of them were on derifylin, and some of them were also on corticosteroids off and on. And this shows that they had significant amount of impact on their quality of life. Frequency of exacerbations requiring oral steroids, as you can see, monthly, bi-monthly, daily symptoms of breathlessness was the usual story. A lot of them actually have hospital admissions requiring oral corticosteroids, IV corticosteroids, getting into ICUs as well. And most of them have a poor lung function. Now, if you look at phenotyping, then most of them have IgEs which are higher than 100, and their eosinophil count are also in this range. As you can see, that the eosinophil count, which is thought to be cut off like 150 or 300, may not be suitable for the Indian population, because in India, eosinophil count tend to be higher, especially with parasitic infections and other reasons as well. So it is not just the eosinophil count which you are looking at. And as I said, in 2 of our patients, they were actually an SPT or serum IgE negative. But some of them were actually positive to perennial allergens as well. So we tried omalizumab in 8 of our patients. One of the child failed omalizumab, was shifted to mepolizumab, even failed on mepolizumab, and actually has been lost to follow-up. The other patients seem to be doing reasonably well. And this is the response what we have seen in our patients. So there has been a significant reduction in the exacerbations which we have seen. There has been a marked reduction in the use of oral corticosteroids, and most of them are actually off corticosteroids. And the lung functions have improved significantly. And I'll just talk about how do you look at response in the next few slides. So if you have a child who has a difficult to control asthma, you're looking at confirmed asthma. That's one. You're looking at adherence technique, looking at comorbid smoking by the patient. A lot of them might be vaping, especially in adolescent age group, and leading to a poor control. Look at their allergens, look at their trigger, and look at their psychological issues as well. And this needs to be done properly before you actually go on to the next step of treatment. Try and optimize their treatment, try and assess phenotype, try and identify treatable traits, and try and put an asthma control test and follow them up. But if they still seems to have persistent symptoms, severe exacerbations, significant airflow limitation, and the need of oral corticosteroids, right? So these are the 4 things which you are looking at. Then this is a child who falls into a severe therapy-resistant asthma. Remember that children with severe asthma do have a lot of comorbid conditions which are associated, and don't forget them. They can be allergic or non-allergic rhinitis. They can be nasal polyposis. A lot of patients have vocal cord dysfunction or exercise-induced laryngeal obstruction. They can be aeroallergen sensitization. They can be reflux. They can be obesity. They can be obstructive sleep apnea. They can have dysfunctional breathing. They sometimes can have an EBPAS. So these are, and a lot of them, or most of them, actually have anxiety and depression because of their poor quality of life. All these comorbid conditions need to be dealt properly in this set of patients. Now, a lot of patients with asthma sometimes can have similar symptoms which are not because of asthma, and this is what something which we have gradually learned. So children with asthma tend to have more of habit cough. Children with asthma, known asthma, can have vocal cord dysfunction or dysfunctional breathing in between. So what I'm trying to say is that it is on top of the asthma. It is not an isolated thing. So habit cough isolated is very common. A lot of patients with asthma get an habit cough. Then you can have GRD, anxiety, deconditioned child. So for example, a child with asthma comes back and says, I still get breathless with exercise, and what are you going to do about it? So is it a child with asthma who is doing worsely? So sometimes what you find is that the lung functions are normal, they're actually doing well, and they're just deconditioned because they have not been exercising, and it is not an indication to increase treatment. You actually need to do some physical training in these sorts of patients. Associated obstructive sleep apnea, which is very common. Some of them can have associated tracheomalacias. That is quite common, as we have seen in clinical practice, and some of them can have an associated bronchiectasis, but they can have an overlap phenotype. So when you're trying to choose biologics, you're trying to identify the severe asthma and match them with comorbid conditions. You're trying to match predictors of response to choose appropriate biologics. You're trying to look at eligibility criteria for anti-IgE versus the anti-IL-5 or anti-IL-5R versus anti-IL-4R. These are the things which are usually available. You're trying to see whether they are atopic or eosinophilic, or type 2. And you're also trying to look at treatable traits which can help you in treating these children in a better way. So this is the way most people would do it. So it's T2 high with atopy, IgEs which are higher than 100, which is high, usually more than 30. Some people also look at a response to intramuscular triamcinolone, usually 80 milligram. So what you're trying to do is use omalizumab or mepolizumab. If you find that the phenotype is overlapping, you would start with omalizumab and we might shift to mepolizumab because the largest experience is with omalizumab. If you have biomarkers which are negative and you have to look at 2-3 times to it, definitely rule out differential diagnosis, do a bronchoscopy, do a CT, and if it is still negative, you can consider this to be a T2 low. But in our experience, T2 low asthma is not something which is very common in pediatrics. It is more of a suppurative lung which has been missed. Now, the response to biologics can be, complete responders or super responders. So around 4 of our patients are super responders, and once you put them on omalizumab, they are absolutely fine. They don't need any salbutamols, levosalbutamols, oral steroids, and they're doing absolutely fine. The lung functions are coming up. But there's a group of patients who are partial responders, and 2 of our patients are partial responders where I have been able to take them off oral corticosteroid, but they still do wheeze in between. I've not been able to take them off the rest of the controller. So the aim is to bring a child to a moderate dose ICS with LABA, right? So if you can bring a child to this level, then your job is done. You're not trying to stop all form of inhaled corticosteroid and get this child off treatment. That's not the aim. The aim is to bring the child in around step 3. So if a child is well controlled for approximately an year, what you try and do is reduce the dose of omalizumab or increase the interval. It has to be a practical decision based on what dose the child is on. So supposingly the child is on alternate 150 and 300, then I would stop the 150 and continue 300 milligram every month. And then you can reduce it by 50% to 150 milligram every month, or you can give 300 milligram every 2 months. So that's the way everyone would do it, although we don't have very standard guidelines on tapering biologics. Do we have any long-term data? Well, yes, we understand that biologics may not be disease modifying, and a lot of people have shown, especially in adults, that the disease in most patients would come back. But in the pediatric age group, that may not be true, and that what has been seen is, as shown by the SARP cohort as well, that omalizumab might change the natural history of asthma in a group of patients, and they can actually become, from a severe asthma step 5 to step 3 or 4 level, and that can be a big boon. So, what can happen is that there can be, a spontaneous remission or a drug-free remission, which can be there, but there can be remission and relapses, and that is something which is very common with biologics. And the most important thing which we have to understand is that biologics still are not disease modifying. So just some take-home messages that, please remember that most patients with difficult to control asthma, it is basically a combination of faulty basic steps and comorbid conditions, and that would constitute more than 95% of patients. Now, where the trials of severe asthma were trying to be conducted, at most centers, they could not find patients because the moment they enter into the research protocol, they try and do the rest of the things properly. And once those steps are done, most of the severe asthma actually turn into mild or moderate variety. But there is definitely a group of patients which we see who have true severe asthma and they require biologics. Phenotyping, endotyping is something which has to be done so that you can match your child and the comorbid conditions to the appropriate biologics. And I think cost is the most important limiting factor. So thank you very much. And I think I've shot over time. So apologies for that.
Thank you, Dr. Ankit Parekh. Difficult to treat asthma is also difficult to understand. And I can vouch on that you every time make it a little easy for me. And every time I learn something new from your talk. So we have some questions. So Dr. Gautam Ghosh wants to ask, exhaled air eosinophil count, can that be reciprocated in children?
Sorry, can you repeat the question?
Exhaled air eosinophil count, can that be reciprocated in children?
See, in the pediatric age group, doing these biomarkers on sputum is not very easy. So people have used volatile organic compounds. People have tried to use induced sputums, but most people across the world have failed. So even if you look at adult guidelines, most guidelines now do not include an induced sputum, even for the adult age groups. So apart from at the moment, if you look at if you're not looking at the research, if you're looking at clinical work, then most people will do pheno and eosinophil count and IgE, and either a serum specific IgE or an SPP. So these are the usual things which are done, and you look at your clinical history and clinical picture with the lung function.
And then one more question, that do LAMA act both in eosinophilic and non-eosinophilic resistant asthma?
So LAMA is indicated for both. LAMA is a non-biologic step-up, which has shown to be very useful for children across all ages. So it is off-label less than 6 years of age. There are some trials between 1 and 5 as well. But I think a lot of patients who were to be shifted to biologics are really prevented because of the LAMA step-up, which we have got in the last 5, 6
How
years.
long can we use this LAMA before we decide for biologic?
So I don't think there is any upper limit which has been described for LAMA. You tend to follow up this child, and if this child is doing well for around 3 to 6 months, then you try and taper it. There's a group of patients where the moment you taper LAMA, they will decompensate, and if you add a LAMA, they are very happy about it. Their exacerbations and all these go off. So in some of these patients, we tend to reduce the inhaled corticosteroid, keep them on LAMA, although that's not the usual guideline. And then later we try and take them off LAMA, but there is no.
How much maximum dose we can reach? 18?
So yeah, so the 18 is the maximum dose. Usually we do it like around 9 micrograms in younger children and 18 microgram in older children.
So thank you so much, sir. And any comments from our listeners or from the panel? We would appreciate that. And this was a really informative talk at this hour. And thank you. I would like to thank the National Chapter of Pediatric Allergy Association and Immunology, Dr. Neeraj Gupta as chairperson, to give me this chance to be in an interactive mode with all these eminent speakers. And also thankful to Dr. Narayan Reddy and Dr. Krishna Mohan. And definitely our all eminent speakers, Dr. Sitesh Roy, Vijay Ward, and Soumya Nagarajan and Dr. Ankit Parekh. Thank you so much. Thank you for keeping us engaged and such beautiful sessions. And in this, our series with Biologics, we still have a session tomorrow. And tomorrow session is again at 8 p.m. Please do join us. And we have some renowned speakers with us who will be talking us on chronic urticaria, atopic dermatitis, and ocular allergies. In these conditions, what is the role of biologics and their experience, and what does the future hold for us in the biologics? So with this, Dr. Neeraj, shall we end the sessions?
Yes, please. Thank you. Thank you.
Thank you.
Excellent. Thank you.
Very good night to all of you. And thank you once again for such a nice and interactive sessions. Thank you all.
Thank you.